And these are all the pathways of the vomiting and various causes. We'll not go into this diagram, we'll come here. So these are all the causes of vomiting. These are the GI causes of vomiting. Like any organ inside the abdomen, when it is stretched and inflamed acutely, you get vomiting. That is hepatitis, all various viral alcoholic drug-induced hepatitis, pancreas due to any cause, cholecystitis, any gallbladder pathology, peritonitis due to any inflammatory pathology or infective pathology, mechanical obstruction, gastric outlet obstructions, small bowel pathology, small bowel obstructions, or a colonic obstruction also can produce severe vomiting, and pseudo-obstruction syndrome of GI tract can produce vomiting. These are GI disorders of the vomiting. Then your infections, various infections, viral infections, viral enteritis, gastroenteritis, viral hepatitis you can have, or you can have various food poisonings. Various food poisoning can have Staph aureus, Bacillus cereus, and Clostridium. That is acute food poisoning when we say that can produce vomiting. These are all GI causes of vomiting. Now when you go to the other causes, we have renal failure, we have diabetic ketoacidosis, we have Addison's disease. So that lady I was talking about, she had a panhypopituitarism, she had a thyroid disorder and she had a Addison's disease. So Addison was also adding to the severe nausea. Then various CNS disorders, brainstem disorders, strokes, whatever vesicular artery territory stroke can produce vomiting. Your VNT disorders, vestibular disorders can produce vomiting. Pregnancy, of course, can get vomiting. Various drugs, all drugs in a allopathy can produce sometimes gastritis and vomiting, especially all those NSAIDs can produce vomiting. For this entire list of causes of vomiting, how do you approach clinical vomiting? I told you few cases, I told you causes of vomiting. Now, clinically when you take history of vomiting, you must find out whether it's acute vomiting or chronic vomiting. Acute vomiting by and large is organic, unless there's a psychosomatic disorder, where there's some news in a family, somebody dying in a family, some acute business loss or personal loss, or some problem in a family, person can have psychogenic vomiting acutely. But by and large, acute is organic and chronic can be functional or organic. Timing of vomiting is important. Pain in the abdomen that is relieved by vomiting is important. Contents of the vomiting is most important. So when I take history, I mainly go on the content of the vomiting first, then timing, and then pain of the vomiting I go. I'll tell you what it means, Projectile, non-projectile vomiting. Classical teaching in undergraduate days, if you have projectile vomiting, it is CNS. And if you have non-projectile vomiting, it is all other disorders. But this is given now. This is stupidity. There is nothing like projectile and non-projectile vomiting. You cannot judge vomiting by saying my vomiting went 5 feet distance, so I got severe problem. Right? Or my vomiting went 1 foot distance, so I got less problem. It's stupidity. There is nothing like projectile, non-projectile. It's given up now. Last 15 years this is given up. But still the teaching continues. Still the examiners ask you in exam. So what is this projectile, non-projectile business? In CNS disorder, you have raised ICT. The raised ICT, suddenly the CTZ center in medulla, the vomiting center in medulla is stimulated and patient is unaware, there is no preceding nausea, no preceding retching. The person is standing erect and he vomits, the vomit goes little far. Any other disorder, GI disorder, he has a nausea and retching, so he bends. He bends, the vomiting falls at his feet. That's the only difference. So you can't say the projectile because CNS disorder, it was not preceding nausea. So any vomiting, there is no preceding nausea, you can have projectile vomiting. So this is given up and one should not talk about this projectile, non-projectile, but I include so that I can discuss this and the other symptoms. So let's see what does it mean in history taking. Acute, as I told you, as acute GI infections, food poisonings, anything to do with the medicines, pregnancy, trauma, any visceral pain due to any ischemia, obstructions or inflammatory pathology of the GI tract, you can get an acute vomiting. Chronic vomiting by and large is mechanical, that is subacute obstruction, small bowel, gastric outlet, colonic obstructions, anything is possible. Motility disorders, gastroparesis, we'll discuss gastroparesis a little later. Metabolic means diabetes, uremia, Addison's disease can produce, the endocrine is Addison's disease and myxedema can produce vomiting, and psychogenic. Psychogenic forms a very resistant group of vomiting which is very difficult to treat. And I think you are the best people to treat this psychogenic vomiting. In allopathy medicine, I have nothing much to do unless I go to the antipsychotic drugs or I go on the drugs which are mainly going to make patient feel sleepy and drowsy. So I think you can treat this better than me, psychogenic group of vomiting. But there the history taking is required to rule out the other causes of vomiting. before you say it's psychogenic. So now, vomiting soon after meals means as soon as the person eats food, wants to vomit, all the psychogenic vomiting which you have, the history will be classical what? डॉक्टर साहब वो खाना खाती है ना तो वॉश बेसिन के बाजू में बैठती है, खाना जैसे खाया she gets up, she vomits, again she comes back and eats food. In no organic pathology you do that. When you vomit, you don't come back and eat food. In psychogenic vomiting, that lady or a person wants to impress everybody in the family, look, I'm suffering, you are not doing anything for me. So she eats 2 morsels of food, goes to the wash basin, retching, heavy retching, puts her finger in her mouth, induces vomiting, takes a little food, and acts little too loud to make everybody believe that she's sick. Again, she'll come back and eat food. That's the psychogenic vomiting. But you have a pyloric channel ulcer, you have a gastric ulcer, you have a duodenal ulcer, you have a pyloric channel ulcer, pyloric opening, there's an ulcer there. Moment you eat food, antrum is stretched. These people, the pyloric opening goes into spasm and they vomit immediately. So there is a pyloric channel ulcer. Immediately after food you vomit. Delayed vomiting. Person vomits 1 or 2 hours after food. He eats food. That time is a little uncomfortable, but 1 or 2 hours later he vomits. It's mainly due to gastric outlet obstruction, due to malignancy, enteral malignancy, or pyloric malignancy, or a motility disorder, that is due to gastroparesis, diabetic gastroparesis, or you have a post-vagotomy vomiting. Early warning, nausea and vomiting. As soon as you get up, he has to vomit or she has to vomit. Then pregnancy, uremia, and alcohol. Alcoholic gastritis, moment a person gets up in the morning, is brushing his teeth, severe retching and nausea. That's alcoholic. And if you have increased intracranial pressure, raise ICT. When you take a history of tumor, raise ICT tumor, it's a very important point that the vomiting early morning. As soon as the person gets up in the morning, there is vomiting. And why this vomiting is the early morning? Because the entire night person was supine. When the person was supine, the CSF drainage from the brain occurs into the jugular vein, jugular sinus, into the internal jugular vein. The suprasagittal sinus, inferior sagittal sinus, they drain CSF and they come to the straight sinus, then come to the jugular sinus, and from the jugular sinus into the jugular vein. So when the person is supine, this CSF does not drain well. There is a raised ICT at night time, so they get up with a headache and they vomit early morning. So early morning severe headache and vomiting, think of raised ICT, intracranial tumor. So that's an important point there. And lastly, post-nasal drip. The person has got sinusitis, post-nasal drip, early morning they are uncomfortable, they vomit. If person has got a pain in abdomen, which is relieved by vomiting, he has got acid peptic disease, gastric ulcer or duodenal ulcer. But if the pain is not relieved by vomiting, then it's got a pancreatic pathology, or a gallbladder pathology, or there is appendicular pathology or IC region pathology. So even if the person vomits, the pain does not go and the pain remains. This is the important point. When I take history, I ask about the timing of the vomiting. Then I ask, when is the vomiting related to the food? And the next question I ask is, food. When you vomit, what kind of the food comes out in the vomiters? If the person says, Doctor Sahab, undigested food as it is what I have eaten, I can identify the chapati and sabji in my vomiters, or I can see rice as it is, or dal as it is, then most probably it is a G junction problem. This person has got achillea cardia or CA esophagus with obstruction. So food is from the esophagus only comes out. So food coming from the esophagus, you have achillea cardia or malignancy or pharyngeal Zenker's diverticulum or esophageal abdomen. Zenker's diverticulum is in the neck, cervical esophagus, big diverticulum in the neck. All the food goes into the Zenker's diverticulum and that comes out in the vomiters as it is. Partially digested food or old food. Doctor, what I've eaten 2 days back comes out in vomiting. Or my food is partly digested, but I can still identify something in my vomiters. Okay, it's a gastric vomiting, gastric outlet obstruction, or a high proximal small bowel obstruction, or a gastroparesis. Gastroparesis is mainly in a diabetic person. Almost 30 to 40% of diabetic will have gastroparesis. Here the gastric tone is markedly reduced. The fundus of the stomach and antrum relaxes, and there's a dilated antrum. So this person, the antropyloroduodenal movement is lost. So